Thank you.
Respected Chairperson, moderator, and audience, good evening. I'm very honored to be here to present this case in this learners gathering. Our patient, 82 years old, frail female patient, diabetic, CKD, and COPD. She has a history of chronic stable angina, admitted in another hospital with unstable angina. CUG was done in that hospital and transferred to our hospital for revascularization. Her ejection fraction was 48%. This is the ECG. Creatinine was 1.9, HbA1c 8, and hemoglobin was 9.8. This angio shows heavily calcified with 90 to 95% stenosis in distal segment of left main artery, involving origin of LAD, LCX, and ramas. And RC having 90 to 95% stenosis in mid segment. So what to do? Old age, female patient, diabetic, CKD, COPD, already surgeon has refused. So all those so we decide for stage PCI, tackling the RCA first. We put 3 into 30 millimeter DS in the mid RCA, shows good distal runoff. After 3 days, we decide for tackling the left. You can appreciate the fluoroscopic view of the left. Chunk of calcium involving the left main, LAD, and LCX. So we take femoral root, 7 French, and EBU. So heavily calcified 90 to 95 stenosis in distal LMCA without involving original LAD LCX. First we try to wire left main to LCX with the floppy wire. Our workhorse wire is run through floppy wire. We usually, in this case, we prefer to make support with a microcatheter. As we feel little resistance during the wiring, so we decide for rotablation. We take 1.25 bar. And then rotate one, usually our default rotation, one like 80 to 85,000 rotation per minute, usually in our center. So first poke the left main to L6 ostium, then go further. Each attempt was 10 to 12 seconds. Then we exchange our rota wire with the floppy wire, and this is you can see the flow is good enough. Then we decide for go to left main to LAD. With wiring LED was challenging due to heavily calcified. Run through floppy wire taken with the help of fine close catheter. Then exchange with the rota wire. We again take 1.25 bar from left main to LAD. And then from left main to LAD ostium, and then again further, 1/80 rotation per minute. Then we took our IVAS catheter and found still there is a chunk of calcium. We need more. So we step up our bar, 1.25 from left main to LAD. Again, 180 beat, 1 rotation per minute. Then after rotation, we take our rota wire with the exchange the floppy wire. This is the flow after the rotation. So we think we need more pedalate. So we take 2.5 into 50 millimeter NC balloon from left main to LCX and LCX proximal. Then as there's a left main to LCX and neighboring LED was heavily calcified, we decide for upfront double stand strategy, our plan for decay crash. So we take 2.5 28 millimeter DS left main to LCX and 3 into 50 millimeter NC balloon into left main to LED. And LCX stent was deployed at 12 atmosphere. LCX wire and balloon was removed, and LCX stent was crushed by LED balloon. Then rewiring of LCX with the help of fine cross microcatheter. Then our first casing done, 2.7 50 millimeter NC balloon in left main to LCX and 3 into 50 millimeter NC balloon in left main to LED. Then we take 3 into 30 millimeter DS placed from left main to LED, and LCX wire is removed and used as a Caspal wire technique. And a stent was deployed in 9 ATM. Then a stent balloon was pulled back and inflated in high pressure. After the deployment, this is the flow was quite satisfactory. Then we put 3.5 into 8 millimeter NC balloon in high pressure at 24 ATM. After that, we rewiring the LCX with the help of fine cross microcatheter. Then our final casing done. After the casing, this is the flow. We report within 3.5 into 8 millimeter NC balloon. This is the final result with the TB3 flow. So flail elderly patient with calcified vessel, multiple comorbidities, high bleeding risk are often poor candidate for CABG. Rota ablation with multiple vessel left main PCI is an attractive alternative. And decay crash is safe and effective method to tackle the complex distal left main disease. So thank you from our NHF team.